Pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen, I'm a Bristol GP working for the BNSSG Training Hub, bringing baby, child and young person education to primary care clinicians. Today I'm delighted to be joined by Dr Rachel Gaywood, who is the GP Clinical Lead for Learning Disabilities and Autism in Devon. Hi Rachel.
Hi.
Thanks for joining us today.
No problem.
Would you mind telling us a little bit about yourself and how you ended up in this field?
Sure. I've been a GP for more than 15 years now, but as a teenager before I went to medical school, I worked in local special needs play schemes, went on trips with local children with special needs. So it's always been an area of interest. And when I became a GP, it was just as the annual health checks were being brought in. So one of my roles was to start up the annual health check scheme in the practice. Where I work now, I'm the practice lead for learning disability and adult safeguarding. So when the NHS Devon job came up, it seemed like the natural next step, really.
Fantastic. So some brilliant expertise to share with us today. So today we're going to have a bit of a general chat about learning disabilities and then delve into a couple of cases to explore common themes that we might come across in primary care. So Rachel, first of all, what is a learning disability?
Sounds like a straightforward question, but often not so well understood. Officially, to have a diagnosis of a learning disability, you need three things. The onset before the age of 18 and have a lasting effect on a person. It has to include impaired intelligence, so a reduced ability to learn, and also an impaired functioning, so reduced ability to cope day to day. That's officially the three things. We don't tend to check IQ anymore, but officially it would be an IQ below 70. We often, in general practice, misunderstand the difference between learning difficulty and learning disability. A learning difficulty can be something like dyslexia, which doesn't affect your intelligence. In some countries, they use intellectual disability rather than learning disability as a term.
So that's one common one that we get mixed up with, but there's also developmental delay. Is there an overlap?
So developmental delay often indicates a learning disability. It's not one of the codes that is used to pull through onto the learning disability register when somebody becomes an adult. So that's really, really common. When you see a paediatrician when you're under 10, nobody wants to commit to what might happen later because sometimes it's unknown, isn't it? We don't know how somebody might develop. And you can have a speech and language delay, for example, but it not affect your intelligence or impair your learning long term. So people sit on the fence, they don't want to commit too early, so they'll say something like global delay. That code will stay in that person's notes. And it may well be that that person has a learning disability, but we might not know about them. That's the kind of thing that we need to be aware of, really.
Okay. Are there any common misconceptions about learning disabilities that you encounter?
All the time. People who make assumptions about what a person can and can't do, what a person can and can't understand. Often a person can understand a lot more than we think they can as long as we communicate in the right way. So it's a communication barrier, but that goes two ways. It's not just that they can't communicate to us, it's that we're not communicating and giving them enough accessible information like easy read leaflets and such. So yeah, misconceptions all over the place.
Thank you. What age do learning disabilities typically become noticeable?
In some children, their milestones will be delayed from very early on. In other children, particularly if they have more of what we might call a mild learning disability, they might meet their milestones and it might only become apparent when they go to school, for example, that they're having challenges. What we see in neurodiversity, but also in learning disabilities, that children learn to mask. They learn to fit in, and it's only at times of transition they really struggle, which is why it's important that we recognise people when they're 14 and over. We manage to get them on the learning disability register so that we can offer them their annual health checks and we can support them through that transition time. But it obviously has to be before the age of 18 and you would expect some signs as a young child.
What's the role of primary care or the education sector when it comes to diagnosis or even referral?
You don't necessarily need to refer. To get an annual health check, you just need to be on the register. So you don't have to have a formal diagnosis of a learning disability. You just have to have that learning disability identified. And we can do that in general practice. And there are various tools available to help with that, which we'll probably go into a bit more later. We would expect the school and the families to be working with the SENCO at the school and getting an educational psychology report if needed. We would expect it to be identified through that route initially. Obviously, if they have co-occurring medical conditions, then a paediatrician will be involved. but it won't usually be the GP who is assessing and diagnosing a learning disability. We might be recognising it.
Okay, thank you. So coming on to our first case, Dad brings 5-year-old Manu with Down syndrome and mild learning disabilities to the surgery as he's been showing signs of intermittent abdominal pain for the last 2 months. Manu was potty trained at age 4 and still has the occasional accident not recognising the need to open his bowels in time. Manu started to become resistant to opening his bowels. Dad thinks it's causing him pain, but explains that Manu tends to communicate more through gestures when he's upset, unwell or in pain, using fewer words, so it can be difficult to understand. He's currently opening his bowels approximately every 3 days when he passes large volumes of usually type 3 stools. He has a restrictive diet of mostly beige foods. Parents struggle to encourage him to drink sufficient fluids and realise that he's been avoiding opening his bowels at school since starting mainstream school 3 months ago. Parents are separated with shared custody. Rachel, is there anything else you would want to know in the context of this case?
Full history and examination. What we want to really avoid is what we call diagnostic overshadowing. So we can't make assumptions about Manu because of his Down syndrome and because of his learning disabilities. We need to make sure that we've considered all of the physical conditions that could be going on here. We want to know if there's any history of celiac disease, which is more common in Down syndrome. Weight, systemic signs. We can see that there's an environmental change recently. He started school. He's got 2 different homes that he's living in. So we'd want to know a little bit about the difference in terms of diet and environment there. But mostly it would be not about making assumptions.
Okay. And do you have any general tips when assessing a child or young person with learning disabilities? You've touched on a couple there with the diagnostic overshadowing and not making assumptions. Any other specific tips you'd want to share?
So number 1 would be listen to their parents or carers. I like to quote the ADHD guidance, which says these children need above average parenting. Unfortunately, any parent of a child with special needs will have encountered negative judgment in their life. Often that will be people assuming that they're worrying unnecessarily or they're over the top in terms of their concern. But the main thing is that we should be listening to them and what they're telling us. It's really important to know what a baseline is for Manu, which is really important when we think about the annual health checks. One of the reasons to do them every year from the age of 14 and over is so that we know what that person's baseline is. Then we can notice if there's a change to that. Knowing how they communicate, making efforts to communicate with them, and knowing how they communicate when they're in pain or distress. Really important to listen to that.
Thank you. And so then thinking about how to manage Manu, let's go on and assume that we've done an examination, which is largely normal, and there's no other concerning features in the history. So our main differential at this point is constipation. Are there any other additional factors that should be taken into consideration, considering constipation in the context of Manu's learning disability?
So unfortunately, we know that constipation is really, really common in learning disability. The LEADER review, so LEADER is learning from the lives and deaths of people with learning disability and autistic people. Constipation is one of the conditions that people with a learning disability can die from. I still find that shocking, even though I know it to be true. No one should ever die of constipation. It's really, really common in learning disability. What we also know about Down syndrome specifically is that you can have bowel mobility problems. So it's being aware of the particular syndrome that a person might have if you know what that is. Again, knowing what that syndrome might lead to. Down syndrome is a common cause of learning disability, but obviously there are many, many other conditions out there. So I would say learning about that condition is really helpful and getting the multidisciplinary team around that person. In a young person, it's not just the parents, but we're going to need the school's involvement, potentially school nurses, Senkos. So any plan in terms of their constipation, their bowel management is going to need to be across all of those settings that child is managed within.
Thank you. Are there any resources around constipation in children with learning disabilities that would be helpful to signpost the parents to?
I would sign people towards ERIC. They do have a learning disability and autism page on the ERIC website. That's useful to look at. Particular syndromes will have their own websites and resources. So the Down Syndrome Association has information on their website about bowel problems in Down syndrome specifically.
And constipation is very common in children and young people with learning disabilities for a number of reasons. So as in the case of Manu, restrictive diets, poor fluid intake, communication difficulties. potentially physical disabilities, medication side effects. Are there other mental and physical health conditions that children and young people with learning disabilities might be more susceptible to?
The short answer is yes. Many mental health conditions overlap with learning disability as well as neurodiversity. In the past, we've made assumptions saying, that condition is to do with their Down syndrome or that's to do with their learning disability. They're not anxious, they're autistic. But we know that there is a big overlap. And a person with Down syndrome can also be autistic. There's no reason why the two things can't coexist. It's about avoiding that diagnostic overshadowing and putting everything down to the cause of the learning disability and considering the other conditions that may go alongside it. And also bearing in mind that people with a learning disability may well struggle for lots of reasons, which can predispose them to mental health conditions. So we get a lot of adults with a learning disability who have picked up other labels, for want of a better word, along the way that may be incorrect. And if we'd actually supported them better when they were younger, we might have been able to support them and avoid those difficulties into adulthood. So really important to notice and get the right support early on.
We've spoken a little bit about schools and support there. Is there any other general support available either to the children or to the families that you think would be helpful at this point, using Manu as an example to refer or signpost to?
Yep, so most areas will have a children's disability team. They'll have an information and advice service through the schools. They'll have obviously Senkos and pastoral support within the schools. The first port of call for anybody coming through general practice would be to make sure that they've tapped into whatever support is available in their community. Obviously, there's online support. So depending if you have a specific syndrome or whether it's a generalised learning disability that hasn't got a specific name, there is lots of support out there. There's a website called Unique, which is for specific chromosomal disorders, the more rare conditions that there may only be a handful of people in the world. They're a great resource for joining people up with other people in different areas who might have the same condition. So specific condition organisations, community teams, schools, online support. It's really about finding your tribe of people who can support you.
Fantastic. And Unique's not one I've heard of, so
Okay.
That's really helpful to know. And then thinking about our second case, Mum presents with Martha, who's about to turn 18, looking for advice. Martha has cerebral palsy secondary to meningitis as an infant, with severe learning disabilities. You notice that learning difficulties rather than learning disabilities is coded in the notes. She's just been discharged from community paediatrics after long-standing 6-monthly reviews, with considerable input from a paediatric physio, occupational therapy, speech and language therapy, and an educational psychologist. Martha is in her last year of education at a special needs school where she has an educational health and care plan. Martha lives at home with her mother, who has MS. Martha uses a wheelchair. She's able to independently feed herself with adaptive cutlery, but requires ongoing assistance with washing and dressing. Mum is worried that Martha's been discharged from paediatric services without an ongoing plan for support, so she's looking for advice or potential referrals to adult services. Rachel, what are your initial thoughts on this case? Is this a common scenario?
So yes, this is a really, really common scenario, and one of the reasons why the annual health checks are now offered from 14 and over, whereas originally it was 18 and over, because we know that transition from children's to adult services is really, really challenging for young people and their families. In Martha's case, she's been surrounded by a community team, a special school, her family throughout her whole life. When she becomes 18, those people are slowly going to disappear and she will be left with us, her GP. And GPs are great, but we might never have met Martha because she's been surrounded by all these experts. So by identifying her needs at the age of 14, by making sure she's on her annual health check register, we can slowly start to introduce her to the practice. We can get her in every year. We might not even examine her for the first couple of years, but at least she's getting used to coming to see us. The family know who we are. And that's not so terrifying when you turn 18 and you effectively drop off the edge of a cliff in terms of support. Really common to see that she doesn't have the correct codes on her notes. We touched on this earlier. So she's got learning difficulties in her notes rather than the learning disability code. Martha's not even going to be picked up on our learning disability register unless we change that. In our area, we did a project with local special schools where we encouraged them to learn about annual health checks in their preparing for adulthood lessons. And then the schools supported them to write to their GP learning disability champion. So in Devon, we have a champion in each practice. They wrote us letters. and said, this is me, please can I be on your register and please can I come in for your annual health check. This was in the special schools. My local college, their clients are all people with severe and profound learning disability. So there's generally not much doubt there about whether they should be on the annual health check register. Yet 30% of them I didn't know about because they didn't have the right codes. They all had the codes like global developmental delay or learning difficulty. So we've got a lot of work to do. And the first step, I think, is noticing. So if we notice that code, start asking questions. Should they be on the annual health check register? I've never come across a family or a young person who has been offended by me giving them a ring and asking them if they want an annual checkup. Most people are delighted that somebody's noticed that they're there and is offering them some health support. Use the inclusion tools. There's a great inclusion tool written by the Get Checked Out team in Leeds. Mm-hmm. That's the one that NHS England recommend that we use, which is a really easy tool for GPs. Lots of yes/no tick boxes on it that ask questions like, where did they go to school? Did they get any qualifications? What support do they need with everyday life? Did they have an EHCP? Various questions which can help us decide whether or not somebody should be on the learning disability register. Now, as I say, we're not diagnosing their learning disability and we're not offering them anything specialist. We are offering them an annual health check to identify any conditions that might come along, flu vaccine, COVID vaccine, screening. What I always tell my colleagues is that very little harm will come from somebody being on the annual health check register. Get on the learning disability register. All you need is the code. Don't need to make any conclusions about the severity of someone's learning disability. You don't even need to diagnose it. You're just adding them to your register, which is subtly but importantly different to diagnosing their learning disability, which many would argue is not a GP's role. About 2 to 2.5% of the population have a learning disability, and we only have about 0.5% on our learning disability registers in general practice. So we are missing 3 in 4, and that's really shocking. NHS England only last week have published a leaflet about finding out more about the learning disability register, which summarises most of the things that I've just said. Tells us about the diagnosis of a learning disability, as we mentioned earlier, the 3 things. So age of onset before 18, impairment in intellectual functioning, and your adaptive or social functioning. In Martha's case, first thing will be to get the code on her notes that she's on the learning disability register. It's unlikely that that's going to be controversial given the history, but we would speak to her family and to Martha about that.
So putting a code on the notes, you wouldn't equate that to making a diagnosis. You would consider that more identifying. That's
identifying somebody as benefiting from an annual health check. It's adding them to your learning disability register. Sometimes that can create some difficulties in terms of our specialist services. So many of our specialist learning disability services quite rightly are set up to use their specialist skills to support the people with the most severe and profound learning disabilities. What we would hope and what should be happening is that anybody whose needs can be met within the mainstream with reasonable adjustments have those needs met. So we have this 2-stage process, don't we? We have the people who need that specialist support and should absolutely be supported to get that. And then we have ensuring that everybody who works in healthcare knows what reasonable adjustments are, has an awareness of learning disability and neurodiversity, and can make those reasonable adjustments in order to help those people to access those services. We have the Oliver McGowan training, which is now coming in. Everybody should be having Tier 2 Oliver McGowan training if you're face-to-face with the general public in healthcare. That is the ambition, and it's mandatory now that we all have reasonable adjustments training, with the Oliver McGowan training being the government's preferred training.
Okay. And we've touched a little bit on EHCP, so Educational Health and Care Plans, in previous episodes, but can you tell us a little bit more about them in the context of a learning disability? So just briefly, what are they, and does every child with a learning disability need one?
An EHCP is something that a school or a family can apply for if their young person's needs are not being met in the school environment. So schools have a certain budget and they have a certain amount of resource that they have to use to support each child, and they have to evidence that they've used that support. If that child needs more support than they can provide, then that's when they will start applying for an EHCP. So you need evidence from the education, you need evidence from health, the name's on the tin, and all of that evidence is put together. Now, it's really uncommon that a GP will be asked to provide evidence for an EHCP because it's usually the specialist teams, it's usually the schools, it's usually the educational psychology reports that are used. But there is a chance that we might be asked to provide some evidence for that. What I would like to see is that we see copies of the EHCP summary at least once in the person's life. If we could all receive the EHCP at the end of year 9, so when the child is 14, then that would help us to identify learning disabilities. Because I think people assume that the systems talk to each other better than they do. And often in general practice, we have no idea who out there is needing all of this support in the schools. It's when they go through that transition and that support's no longer there for them that they are knocking on our door and neither of us have met each other. And that's why it's good to be aware of what an EHCP is. In answer to the question, not every child with a learning disability will need one because it's based on the needs. If their needs are being met within whatever environment they're in, then they may not have an EHCP.
Brilliant, thank you. So can you talk us through your approach to this case? What would you do?
I would have a look through her notes, clarify the history in my mind, then I would offer to add them to the Learning Disability Register. I'd get them in for their annual health check. That might be with a nurse, GP or a combination. Practices do it differently. In my practice, we try to do annual health checks in a clinic style. So the nurses will see the patients and then a social prescriber will have myself, we'll have a pharmacist all on hand to deal with all of the other issues that need covering within the annual health check. That would be the first step with Martha. We would also want to add Martha's mum to our carers register, put her in touch with the carer support worker within the practice. And we can see that she has MS. So we need to start thinking about longer term planning for Martha and her mum, which might involve getting health and social care team involved to look at their needs, whether they have any daycare support, whether there's any respite needed. So all of those things. And again, the annual health check's a real opportunity to do those things well in advance and to plan that so that it doesn't hit crisis point. The last thing we want is something happening and Martha being left in crisis and nobody knowing anything about her. And this is really common. And this is why it's important to identify the people out there who might have a milder learning disability, who might cope with the support of their community around them. And these are the people that I worry about the most. They're the people who might be in their 50s, who have lived with their ageing parents and been supported throughout their whole life. And then something happens to one of those parents. And suddenly we're aware of a person with a learning disability who's never had any of the appropriate health support. And by then they may already be facing the health inequalities. So it's about recognising people early on so that we can offer them the support they need.
Thank you. With Martha, who's about to turn 18, are there any other particular areas that you would want to think about with her, just given her age?
Yes, so in young people, there are lots of things to think about. Again, Leader tells us that there are a number of conditions which are more common in people with learning disabilities. We know that Martha is a wheelchair user. She's been seen by speech and language therapists. She's had lots of physio input. So we want to know about her swallow. Does she have any dysphagia? Unfortunately, aspiration pneumonia is a common cause of death in people with learning disabilities. So we need to make sure that we've considered that. Epilepsy as well, really common in learning disability. So we need to think about whether that's something that's going on for Martha and how we're managing that in terms of medication. For young people specifically, we also need to consider sexual health. It's a really difficult topic because people don't want to assume, but we do make assumptions about people with learning disabilities. We make assumptions that they don't have sex or that they don't want to have sex. And why shouldn't they? Unfortunately, we also know that people with learning disabilities are more vulnerable to abuse. So we really need to think about asking about sexual health, asking about relationships, giving them some support with healthy relationships. We need to think about screening. We need to start thinking about, particularly if she's 18, if she is going to have a smear test in the future, desensitization maybe if that's going to be difficult for her. That's the thing about the annual health check is you can start these processes off. So you don't have to do everything on the first time you meet them. But if you know that somebody has a needle phobia and won't tolerate a blood test, or you know that they're going to find a smear test challenging, then you've got time to do that desensitization work, either at the practice or with the learning disability team's support, so that we can give them those screening opportunities that they have every right to have. The concept of misguided kindness. So people will often say, oh, she's never had sex and it would be really distressing for her to have a smear test, so we won't put her through that. That's come from a place of kindness. Nobody likes having a smear test, but we all have a right to have one. And why shouldn't Martha have the right to have that screening test that could potentially identify an early stage cancer that is treatable? People with learning disabilities are more likely to die of cancer and it's more likely to be found later. One of the ways to tackle that is to ensure that they can access the screening tests that they're entitled to, whether that's through providing accessible information, whether that's through reasonable adjustments. But the annual health check is an opportunity to at least notice that and to talk about it with them. The other thing to consider, which again, I don't think we always get 100% right in general practice, is that when a person becomes 18, their families no longer legally can make decisions for them. And I think that's not well understood by families. And that can be challenging when a person who you've cared for their whole life and you've parented and are essentially the same person, but now in the eyes of the law, they're an adult. When professionals around them start saying, well, it's our decision now, that can cause a real conflict with families. Being aware of that and supporting families with that is really important, whether that's encouraging them to seek court of protection deputyship for the young person, or whether that's just building that relationship so that you have that really good communication with the families and you can work together in that person's best interests. But understanding of the Medical Capacity Act and understanding the issues that that can bring for people with learning disabilities. We don't know if Martha is able to consent to give somebody power of attorney. We don't know if she has capacity, but often with learning disability, a person will never have had capacity to give somebody power of attorney. So the only way of their family acting legally for them is to go through the court of protection process, which is lengthy and expensive, unfortunately. The support with that part of transition, there is signposting people to local carer support groups. Most areas will have group for carers of people with a learning disability. In our local area, that's through Mencap, but it might be through other voluntary sector organisations. And again, it's about making sure that they know they can access the GP whenever they need to. And just simple things like adding a pop-up onto the notes that says, this person is non-verbal, therefore please speak to their mother. Or this person is on the learning disability register, please communicate through their support workers. I know people tell us that it's really frustrating that they ring up the surgery and they say, I'm ringing on behalf of my daughter. Oh, well, we need her consent because she's 20. They have to repeat this process over and over again. And that's one of the big things that families of people with a learning disability tell us, is that they don't want to have to keep repeating their story. And that causes a significant fatigue and they feel like nobody is listening. In general practice, if we can just listen to them and we can do those reasonable adjustments, so adding the pop-up to the notes, ensuring that they can ring up for their prescriptions if they can't access online, all of those little things that can make a difference to our vulnerable patients. Access to general practice is difficult, and quite rightly, our reception staff, they have to be the gatekeeper to prioritise, but it's about making sure that they know about reasonable adjustments as well, and that they are able to support the vulnerable patients. We're trying to provide healthcare to the people who need it most.
Thank you. So do you have any key take-home messages or calls to actions for primary care clinicians?
Always. Firstly, I would say think learning disability. There are many, many people out there who, if we just notice, if we start to ask the questions, we will automatically increase our learning disability registers. Because I notice, because it's my area of interest, I am often adding people to the register. Just a quick look at their problem list and picking one of the codes up that we've noticed, so global delay or even learning difficulty. Question that. It might not mean a learning disability, but start to ask questions. There are audits that you can do. There are codes that you can search for and audits that you can run to identify the codes that might indicate a learning disability. So that's a really good project for anybody training in your practice. If they want to take on a project about health inequalities, that's a really positive thing to do. I would always say, think of diagnostic overshadowing. So that's when we assume that a presentation is related to somebody's learning disability rather than a physical underlying condition that we're missing. People with learning disabilities have a right to vaccinations, screening, and all of the health promotion that anybody else has. Don't make assumptions about lifestyle, about sexual health, about relationships. Ensure that we have accessible information available, whether that's easy read leaflets, whether that's reasonable adjustments like extra time for an appointment, giving them an appointment at the beginning of the day, at the end of the day. Sometimes it might just be even they need to wait in the car until we're ready to see them, and we can give them a call and say you can come in now because they might find the waiting room overwhelming. So ask about what reasonable adjustments they need. It's a great special interest to have. Taking care of my patients with learning disability is the one thing that helps me to be a traditional GP. We can get that continuity. The annual health check is a great opportunity to see somebody once a year and to really get to know them. I think general practice has changed so much with our triage systems. There are very few people who work full time anymore because we just can't work like that. My learning disability patients are the people who really keep me grounded. I love working with them. Seeing the difference in somebody when you have identified a health condition, managed that health condition, and they're back to their baseline or better is just the most rewarding part of the job. And I think you can be a traditional GP for this small group of people, and it's really worthwhile.
Oh, that's really lovely. Your enthusiasm there coming through. I think for me, some of the key take-home messages from our conversation today is the coding learning disabilities specifically and making sure that is coded, particularly if somebody's got quite a similar code, as you say,
Yes.
and the importance of that. Get checked out. That's a really useful resource that I must admit I don't regularly use, but I'd like to work more into my regular practice.
There are lots of information out there. The team in Leeds are great. They've got lots of really good information. Mencap also have some really, really good information about the Learning Disability Register, about annual health checks. They did a campaign, I think it was in COVID, called Don't Miss Out, just encouraging people to ask to be put on the Learning Disability Register. I think people often feel like they can't contact us. The Learning Disability Register is an incentive within the PCN Impact and Investment Fund, and then they will get the payment for another annual health check. So through the Direct Enhanced Service, annual health checks, we get paid £140 per check. So it is in our interest to increase our Learning Disability Register. And if somebody comes to us and asks to be added to it, as far as I'm concerned, then that's a win.
It's a bit of a no-brainer to say.
Yes, yeah.
The other bits for me were the diagnostic overshadowing. I think that's really important within this context, just to be aware of. And I love that phrase, misguided kindness. I think that's something that will stick with me in making sure that I don't get swept up in those conversations where families say, oh no, for their sake, we don't want to do this.
Yes.
But actually remembering they have a right to these things and we really need to try and facilitate them with reasonable adjustments.
And I think sometimes it's easier to not do something and we can convince ourselves it's in their best interest because it would be difficult. Whereas sometimes we still need to do difficult things, or at least we need to try.
And we've talked about quite a few different resources today. Are there any that we've not discussed already that you particularly wanted to mention, either for children and their families or for healthcare professionals?
There is an overwhelming amount of information out there. There is quite a lot of information on the NHS website. So NHS England, identifying learning disabilities, and that has the inclusion tool within it. As I said, there was a new leaflet produced last week about finding out about the Learning Disability Register. So I would signpost to that. But mostly I would say find out what your local area has to offer. Find out what parent support groups there are out there, because that's where people will find their support and information. We can't and shouldn't provide all of that support within health. It has to come from a community as well. So find out what's in your local area and signpost people there.
Fantastic. Thank you. And I will link under this podcast these different resources that we've talked about and our local BNSSG parent support groups as well. Brilliant. Thank you so much.
Thank you.
The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen and interviewees are not liable for any clinical decisions made as a result of this podcast.